Hello, this is Dr. Lori Gardner from Nicholls State University, and I will be recording on thought disorders for Module 6. So there are 4 key competencies that you'll develop. 1, to differentiate the disorders. You'll learn to distinguish between schizophrenia, spectrum, and other psychotic disorders using the DSM-5 TR criteria. And this is essential for you to be able to make an accurate diagnosis of these thought disorders. You'll be able to do a comprehensive assessment. We're going to walk through how to conduct a thorough psychiatric evaluation, including the patient history, a physical exam, appropriate diagnostic workup to rule out medical causes. You'll develop skills in creating individualized treatment plans and combine both medication and psychosocial intervention tailored to each patient's needs. And we're going to cover the critical legal and ethical issues that you may encounter, including voluntary commitment decisions, capacity assessments, and your duty to warn in dangerous situations. We are, for this module, going to do some case studies, kind of walk through a little bit, get your feet a little wet, and get your minds thinking, what do I do? What comes next? By the end, you should feel confident handling a psychotic disorder across all of these dimensions. Schizophrenia is a serious, long-term psychiatric condition that significantly impacts functioning. So listen, schizophrenia, it will significantly impact functioning. The diagnosis requires meeting some specific criteria. At least 2 of the 5 core symptoms present during a 1-month period. Continuous disturbance lasts at least 6 months total. So you have to have 2 core symptoms present for a significant portion of time during a 1-month period with continuous signs of disturbance that persist for at least 6 months. So what I will tell you, think about schizophrenia, schizoaffective disorder, schizophreniform. These all have timelines. So you need to remember the timelines and they will help you with the diagnosis. Schizophrenia, there is a functional decline. So there's a marked deterioration in their work, their relationships, their self-care, compared to how they were before. Core symptoms. Let's talk about the core symptoms. They may have delusions, which are false beliefs. They may have hallucinations, where they may hear things that other people can't hear. They may see things that other people can't see. They may feel things on their body that's not really there. They may have disorganized speech. They may be grossly disorganized or have catatonic behavior. Or they may have some negative symptoms like reduced emotional expression. They're really flat. They may have reduced motivation or speech. The duration matters. Remember the duration. They need at least 1 month of active symptoms. But overall disturbance must persist 6 months or more. They may have a prodromal symptom where it's early warnings or residual symptoms that may appear before or after the active phase. The functional decline is essential for the diagnosis. There must be a clear deterioration in their work performance, their relationships, or their self-care. This is not about isolated symptoms. It's about overall impact on the person's life and ability to function from day to day. Okay, schizophreniform. Schizophreniform disorder uses the same symptom criteria as schizophrenia. They need at least 2 core symptoms, including delusions, hallucinations, disorganized speech, or negative symptoms. The difference is going to be in the duration. So you have to get the durations down. The symptoms last 1 to 6 months total. If it goes beyond 6 months, it becomes schizophrenia. Okay? So schizophreniform, it's like schizophrenia, but it's not going to last beyond 6 months. That's a key difference. Duration. Watch for the good prognostic features specifier. That applies if 2 or more of these are present. If they have rapid onset, confusion at peak of the illness, good functioning before the onset, or absence of blunted effect. So another important thing is that functional decline is not required for the diagnosis. Remember, for schizophrenia, they have to have a functional decline. For schizophreniform, they don't. Always rule out substance use and medical causes. And then early intervention is going to matter. Prognosis is usually better than schizophrenia. So catching it early and treating it aggressively can really make a difference for those with schizophreniform. And then we have schizoaffective disorder. So schizoaffective disorder is tricky to diagnose because it combines two major features: psychotic symptoms and a mood disorder, which is happening at the same time. So they have psychotic symptoms and they might have major depressive symptoms, or they have psychotic symptoms and manic. So it makes it one of the most challenging conditions. Some of the key diagnostic elements: the mood episode, which is depression or manic, must occur at the same time as the psychotic symptoms. This is what makes it different from schizophrenia alone. Psychosis without mood, patients must also have psychotic symptoms. So that's the catch. They have psychotic symptoms, whereas delusions or hallucinations that last at least 2 weeks without any mood episode. So this confirms the psychosis isn't just caused by the mood disorder. And then you may have specifiers like bipolar type, if there's manic episodes, or depressive if only depression occurs. A critical point: the mood symptoms need to be present for most of the illness, not just occasionally. This is what separates true schizoaffective disorder from someone with schizophrenia who happens to have some mood symptoms on the side. Okay? And then there is delusional disorder. Delusional disorder is part of the schizophrenia spectrum, but it's distinct from schizophrenia itself. The key defining feature: 1 or more delusions lasting at least 1 month. That's the minimum threshold. Critical distinction for this one. There's no prominent hallucinations or other psychotic symptoms like disorganized speech or behavior. Functioning remains relatively preserved, and that's important. Unlike schizophrenia, people can maintain their jobs, their relationships, their daily outside activities when they're not delusional. Delusions must last a month or longer. And, very important, the person has never met the full criteria for schizophrenia. Okay? And then there's different subtypes of delusional disorders. There may be the erotomanic, and that's a false belief that someone is in love with them. Oh my gosh, don't y'all know Denzel Washington is madly in love with me? Like, you guys may not know this, but Denzel really does love me. I know. I can tell when I'm watching television, the way he talks, he's talking to me. Okay, so, or someone at work, my coworker. I know he loves me. He just doesn't say it, but I know he's madly in love with me. That's delusion. He doesn't even know I'm thinking this. Or they can be grandiose. That is this inflated self of importance or power or special abilities. Like, I am able to hear what you're thinking. I can hear it. I know exactly what you're thinking all the time because I've got this sixth sense. So if you're looking at me, I just need you to look at me for 1 minute and I can hear all of your thoughts. That's an inflated sense of special ability. I don't have that ability. Or jealous, where there's this unfounded belief that the partner is unfaithful. There is no evidence to support that. But the patient thinks, I know my wife is cheating on me. I know it. She took an extra 5 minutes to get home from work because she had to stop and see her lover. And then, as soon as she got home, she picked up her phone and she looked at it. She's cheating. I know she's cheating. That's unfounded, right? Maybe it was an extra 5 minutes to get home from work because there was traffic. There's road construction, anything. Or there's persecutory, where there's a belief that they're being harassed, conspired against, or spied on. So maybe someone believes the neighbors are watching them. Now, the neighbors don't even know this is going on. The neighbors don't even look in the direction of the patient. But the patient says, they don't look at me because they don't want me to know that they're planning to bomb my house. They've been watching. They've been watching since they moved over there. I know they don't look, but they're spying on me. They've got some plans. They're going to do something. It's not really happening. Or they have somatic subtype, where there's a false belief about some bodily function or appearance of theirs. So their relatively intact functioning outside of the delusion is what sets them apart from other psychotic disorders. Okay? All right, so let's talk about assessment. So we've gone over the different types: schizophrenia, schizophreniform, schizoaffective, and delusional. Remember those timelines. Remember how to separate one from the other. It's really good if you make a little chart that will help you to remember them. Okay? All right. And if I have a chart, I will post it in the class. I think I may have one, so I'll look to post that in the class. So a comprehensive assessment requires multiple different sources to diagnose psychotic disorder. You're going to rule out medical and substance causes, and you're going to plan treatment. So for the history and physical, get complete psychiatric and medical history, including family history of psychosis, any substance use, and the timeline and when symptoms started. Do not skip the neurological exam. That's important. Use a structured interview to assess when symptoms began, how long they've lasted, how severe are they, how are they affecting this person's life? Is it causing a functional impairment? And then the family's input is really important, okay? And then systematically evaluate their appearance, their behavior, their speech, their mood, affect, their thought process, and content. Perceptions, cognition, insight, and judgment. This is going to give you a snapshot of their current mental state. And then order a CBC, a CMP, thyroid, you can get a TSH, a urine drug screen, that's going to be important, HIV and RPR to rule out any medical causes. If it's a first episode of psychosis, you can get an MRI to exclude any kind of brain pathology. So distinguishing symptom dimensions is essential for an accurate diagnosis, treatment selection, and functional prognosis. Cognitive impairment forms a third, but often overlooked domain. It guides diagnosis, treatment choices, and what we can realistically expect for recovery. So, positive symptoms, an excess or distortion of normal function, adding something that shouldn't be there, like hallucinations. Hallucinations are the most recognizable, usually voices, but it can be any sense. Delusions are the fixed false beliefs. Remember, we talked about the common types, either people being after them, things are about them, they have an inflated self of self, or bodily concerns. So that's, you can think about their hallucins. People are after them, it's something about them, they're the greatest, or they have some type of bodily concern. Disorganized speech and behavior are the chaotic manifestations. Speech jumps around and becomes nonsensical. Behavior is so unpredictable or rigid. So that's the positive symptoms, adding something that's not there. Negative symptoms, they can pretty much like talk something away. They don't care. I don't care, the abolition, I don't care. I'm not going to do anything. They don't have any drive to do anything. Alogia. That's the quiet symptom. They don't talk much or they have very little to say. The anhedonia, they don't feel, nothing's fun anymore. They're not enjoying things in life, even things that they used to. They don't want, I'm not going to the gym. That's not fun. Well, no, I don't want to draw anymore. I don't enjoy that. I'm not doing that. Okay? Or they have a flat affect. Their emotional expression just shuts down. Or they're asocial. They start to withdraw. And then cognitive impairment. That's that third piece that's usually forgotten. Working memory, speed of thinking, planning ability, all that suffers. There's deficits there. This often shows up before the psychotic symptoms appear. And this is actually what causes the most long-term disability, even after the psychosis improves, is that cognitive impairment. Psychosis is a symptom. It's not a diagnosis. So we have to identify what's causing it. 4 major categories that we'll rule out. First is mood disorders with psychosis. Bipolar disorder and major depression can both present with psychotic features. Don't assume primary psychotic disorder. You can rule out major depressive disorder with psychotic features, bipolar disorder. Think about stimulants, cannabis, hallucinogens, alcohol withdrawal, PCP. So you got to get through a very thorough history. You got to work through all of these differentials. Medical causes. This is critical. Seizures, autoimmune encephalitis, central nervous system tumors, a thyroid dysfunction, B12 deficiency, even neurosyphilis can all cause symptoms that can cause psychosis. Personality disorders, those are fun. Schizotypal, borderline, paranoid personality disorder, they can mimic psychotic symptoms, but are distinct. So just like I went over some of the subtypes of delusions, I'll do the same when we talk about personality disorders, because they have these personalities that come out and they're almost the same. So you'll be like, well, Dr. Gardner, it sounds like you did that already. Right. So you're using this, you have to figure out which is it. Is it a personality disorder or is it a delusion? First, for any type of first episode psychosis, order neuroimaging and a comprehensive metabolic toxicology workup before you start antipsychotics. This catches any kind of organic and substance-induced cause that might resolve with treatment of the underlying condition. So we really want to know, is this a psychotic disorder or is this something that's substance-induced? Because if it's substance-induced, once that substance wears off, the symptoms are gone. We don't want to have thrown them on an antipsychotic because they came in with a hallucinogen, okay? So second generation antipsychotics are first line. Those are the SGAs. They're preferred because they have fewer movement related side effects compared to older antipsychotics. There's 7 main options. There's risperidone, olanzapine, quetiapine, aripiprazole, ziprasidone, lurisidone, and paliperidone. Choose based on the individual patient. It's not cookie cutter. Consider their metabolic health, how likely they are to take medication consistently, and what symptoms they're experiencing. Clozapine, we save that for treatment-resistant cases. You can use clozapine when 2 other antipsychotics haven't worked. So clozapine will be one of your big guns that you pull out of the closet, not the first thing that you shoot. This is gold standard for patients who don't respond to standard medications. Important to note is that it requires enrollment into a special program and regular blood work because of the serious side effect risk of agranulocytosis. It helps to reduce suicidal thoughts, so it's really good, but you really have to monitor if someone is taking clozapine. No joke. you're going to be monitoring for agranulocytosis. And then there's long-acting injectables, and that's if your patient is non-compliant or non-adherence is an issue. Think about long-acting injectables. They're available in both the older and the newer formulations. There could be the Paradone palmitate. There's aripiprazole monohydrate. There's haloperidol decanate. So these are all your LAIs. And I'm going to refer to long-acting injectables as LAIs for the rest of this lecture. You guys, I'm so sorry. My voice is hoarse. But I'm going to get through this lecture so you guys can have it. Okay, there is strong evidence that the LAIs reduce relapse and prevent hospitalizations. Non-pharmacologic interventions, psychosocial interventions, they're just as critical as medication. They work together for best outcomes in schizophrenia spectrum disorders. CBT for psychosis, or CBTP, that's structured therapy targeting the delusions and the hallucinations, teaches patients to evaluate their beliefs and develop practical coping strategies, reduce distress and functional impairment, and they are backed, CBT is backed by the APA. Family therapy. Educate the families and teach communication skills. Family therapy reduces expressed emotion, and that's a major relapse risk factor. Improves medication adherence and helps families spot those early warning signs. And there's strong evidence for better long-term outcomes when the patient and the family all participate in family therapy. Then there is the ACT teams, or assertive community treatment. That is intensive, team-based approach for severe cases. In Houma, Louisiana, we may have people that are living under the bridge, and ACT team members, they know that that's their patients. They're still going to go out there and take care of their patient. That patient needs a long-acting injectable, they're going to go find them and give it to them. ACT teams are available 24/7 with direct support in the community. Covers medication management, housing, and job training. It is proven to reduce hospitalizations and keep people stable in their communities. So let's talk about legal and ethical concerns, especially when it pertains to involuntary commitment, which may happen. The patient may be hospitalized without their consent if they are a danger to self, a danger to others, or are gravely disabled. In the past, I've gotten the question, well, what about if they're living under the bridge? We cannot admit everybody who's living under the bridge. Everybody who's living under the bridge cannot be admitted to the hospital. So they may get discharged and go back to living under the bridge. That is not being a danger to themselves or a danger to others because of where they live. That's homelessness. Standards are different. So if you're going to practice in Louisiana, you need to know the justification specific for Louisiana. If you're going to practice in Texas, you need to know the jurisdiction specific criteria for Texas. If you're going to practice out of state using another license, you need to know the jurisdiction specific criteria for wherever you practice. Always document the specific clinical basis for commitment. Don't leave that out. That's important. Pursue the least restrictive setting that's appropriate for the patient's needs. So if they can benefit from an intensive outpatient program, try that before you put them in the hospital. And remember that due process protections are in place. Follow them carefully. Capacity assessment is different from competency, which is a legal determination made by the courts. Capacity is clinical and decision specific. So assess that at the time their decision needs to be made. So you're going to evaluate their understanding, their appreciation, their reasoning, and their communication of choice. So, does the patient understand the information that you are providing to them? Can they appreciate how it applies to them? So, do they understand what you're saying? Do they understand that this applies to them? Can they reason through the decision? Can they communicate their choice? A patient with psychosis might have capacity in some decisions, like choosing medications, but lack it for others, like managing their finances. The duty to warn. This comes from the landmark Tarasov case. So that the duty is triggered when a patient makes a credible, specific threat against an identifiable person. Your obligation, warn the intended victim, or notify the law, or do both. Notify that victim and the law. So that is your duty. You have to. HIPAA does not apply there. You have to warn. Document everything, the threat assessment, your reasoning, and all actions you took in response. This is critical protection for both the public and your legal standing. Make sure everything is documented or it did not happen. So we're going to talk about some quality and safety priorities. Safety monitoring is not optional. It's fundamental to managing schizophrenia spectrum disorders. Proactive surveillance prevents serious complications and improves patient outcome. You want to do a suicide risk assessment. Patients with schizophrenia have a 5 to 10% lifetime suicide mortality rate. That's significantly higher than the general population. Use structured assessment tools at every visit, like the Columbia scale or the CSSRS, and we'll go over those a little more. Specifically ask about command hallucinations, feelings of hopelessness, recent losses or stressors, and access to means. Do you have a weapon? Are there knives? Of course, there's probably knives, but what type of knives do you have? Do you have chloroform? Is there some type of poison? Access to means. Remember that clozapine is the only antipsychotic with demonstrated anti-suicidal properties. So consider this for the high-risk patients. You want to do metabolic monitoring. SGAs carry real metabolic risk like weight gain, diabetes, dyslipidemia. Establish baseline measurements early. Check their weight and BMI. Get their fasting glucose. Get a hemoglobin A1C. Check their lipids and their blood pressure. Then you're going to follow up and do this again 3 months after you start an SGA, and then you'll do it once a year. Don't let that, now if you're not monitoring their labs, you need to make sure that their PCP is monitoring their labs. Somebody needs to be monitoring their labs. Olanzapine and clozapine have the highest risk for metabolic burden. So monitor those patients very carefully if they're on olanzapine and clozapine. Then you're going to do the AIMS for tardive dyskinesia. And I would like you to see an AIMS videos. So you will have one in the class that you can look at because you want to see this AIMS being conducted. You're going to examine all the body areas. You're going to check their face, their lips, their jaw, their tongue, their extremities, their trunk. Watch their eyes. So you're going to be examining, even if you're doing telehealth, you still have to do this. You're going to use the AIMS scale at baseline and then every 6 to 12 months. Document the findings carefully to track progression and inform any of your treatment adjustments. So tardive dyskinesia is a serious, often irreversible side effect. So if you want to detect this early so you can manage it. And again, I will put a video in the course so you can watch. It's old, it's an old video, but it still gives you the gist of what you need to know. So, of course, documentation, that's not just about the paperwork. Think of it legally, okay, as a legal and clinical safeguard, especially now because patients have access or should have access to their records when they want them. If you are doing telehealth, that patient should be able to go into the portal and get their records. If you are at a clinic, they should still be able to get their records without jumping through hoops. Okay? Patients have access, they can read it, tell you, hey, this is not what I said. Hey, this doesn't look right. Hey, this needs to be fixed. So think about every note you write should tell a story of what you're thinking. I like to think of every note that I write as going to court. If they had to read this note in court, what would it look? What would it sound like? If I have to get on the stand and read my note, am I going to be able to stand by what's written in this note? What does it sound like? Is it telling a story? Think about your notes that way. Is the DSM criteria met? Don't just write major depression, show it. List which specific criteria are present. How many symptoms? How long have they been there? How are they affecting that patient's life? This is what makes a diagnosis defensible. Document what else you considered and why you ruled it out. Include the reasoning, any labs you ran, what the history told you, and any collateral information that helped you narrow it down. Be explicit in why you chose your treatment, the rationale. What is the evidence? If it's off-label, say so and justify it and make sure the patient knows it's off-label. Note any prior trials, what worked, what didn't, what side effects the patient experienced, and then record that you had a conversation about the education. What did you tell the patient and their family about the diagnosis? What about medication side effects? The importance of adherence, and what warning signs to watch for. Document that this happened, because if you don't, it didn't. Thorough documentation protects your patient, protects you, and demonstrates the quality of your clinical note. Okay, let's do a little case-based discussion. So a 22-year-old male is brought by his parents after 3 weeks of social withdrawal, bizarre behavior, and auditory hallucinations, telling him he is being watched. No prior psychiatric history, urine drug screen is negative, and the MRI is unremarkable. Okay, so he's 22 years old, 3 weeks of symptoms. We see social withdrawal, bizarre behavior, auditory hallucinations with paranoid content. No psych history, negative drug screen, and normal imaging. So this is a realistic first episode presentation. Somebody can come into the ER just like this 22-year-old. So what kind of other history do we need? Put your thinking caps on. What other history are we missing? Do we know anything about the family history? Is there a family history of psychotic or mood disorders? What about substance use? And you're probably thinking, well, Dr. Gardner, his urine drug screen was negative. Okay, but we need to still ask about substance use. Even though that screening is negative, what if he had prior substance use? We need to know details. We need to ask the question. The timeline of the symptom onset. Was this acute or was this insidious? Like, when did all of this start? Any medical conditions, medications, or anything that may have caused the recent stress? We need to know that. And what about his functioning before and any gradual changes? So there's a lot we're missing in this case, right? So there's additional information that we need. What DSM-5 diagnosis is most likely? So we're going to look at the time. Let's look at the time. There's 3 weeks of active symptoms. So we're kind of looking at schizophreniform disorder for 1 to 6 months versus a brief psychotic disorder, which is days to a month, right? So which one are we kind of thinking of here? If symptoms persist beyond 6 months, then he would meet the criteria for schizophrenia. Remember, duration is critical. Critical. Okay. What are the immediate safety priorities for him? So we're going to assess command hallucinations and suicidality, right? That's a safety, big safety. Risk of harm to self or others. Ability to care for himself, his eating, his hygiene, his safety awareness. And then we'll consider inpatient versus outpatient management. So medical workup, that's a non-negotiable. You have to do that before we start any antipsychotics. We want to rule out any organic causes. Family involvement is going to be crucial because they can provide some collateral history and support, so we're going to engage them. Connect with social work for housing, benefits, community resources. And then this is a treatable condition with good outcomes if it's caught early. So that's just a case working through a real life situation. So if we have another case study, I may not go through it. I may just ask questions so you can put your thinking cap on and you can always work through the case. So treatment planning for a first episode. Choose based on the metabolic profile, lifestyle, and symptom severity. Aripiprazole and risperidone are first-line choices for first episode patients. Consider tolerability, and establish evidence when making your selection. Set realistic goals with the patient and the family. Be clear about what to expect. The symptom improvement takes about 4 to 6 weeks. Emphasize the critical role of medication adherence. They have to be compliant with this medication. Involve family members as active partners in treatment because they're the key to success. Then refer to any coordinated specialty care programs whenever possible. CSE is the gold standard for first episode psychosis. Integrate medication management, psychotherapy, supported education, and family support in one coordinated approach. Okay, so you've treated your patients. Now you have to monitor the treatment response. Treatment monitoring isn't just about checking if symptoms improve, it's structured. It's an ongoing process and it's going to guide your clinical decisions going forward. Use a validated screening tool such as the PANSS. PANSS is the Positive and Negative Syndrome Scale, or you can use the BPRS, that is the Brief Psychotic Rating Scale. And that's going to quantify those symptoms. It will objectively measure change. These scales break down symptoms into positive, which is hallucinations, delusions, or negative, withdrawal, flat affect, and general psychopathology domains. So quantifying the symptoms this way removes the guesswork and helps you spot subtle improvements or deterioration. And then side effects surveillance. That's critical. Antipsychotics can cause significant adverse effects. Watch for those EPS symptoms like rigidity, akathisia, dystonia, the muscle contractions. Monitor the metabolic effects. So you're going to keep monitoring weight gain, glucose changes, lipid abnormalities. And don't forget QT prolongation, sedation, and sexual dysfunction. These often go unreported unless you ask them if they're having them. Not QT prolongation, of course, you need an ECG, but if they're really sedated all the time from the medication or having any sexual side effects. Use the AIM scale every 6 to 12 months as a standardized check and document it. If side effects emerge, you have options. You can adjust the dose, you can change medication, or you can add a medication like benztropine. And then remember, symptom reduction is only a part of the picture. The real goal is getting patients back to work, getting them in school, socially functioning, and managing their life. Ask about their quality of life and what matters to them. Patient-reported outcomes are just as important as your clinical observations. Relapse is the biggest threat to long-term outcomes in schizophrenia. Each episode causes lasting cognitive and brain changes. So prevention is optional, isn't optional. It's not optional. Prevention is not optional. It's essential. Okay, so let me say that again. Relapse is the biggest threat to long-term outcomes in schizophrenia. So you're not doing prevention as a favor. You have to do prevention. Okay. There's 5 different strategies that work together. One is medication adherence. That's the foundation. Continuous antipsychotic therapy is critical because if they feel better, they want to come off of the medication and then they're going to relapse. So they need to stay on the medication. LAIs are great for those who have problems with medication adherence. So it's not a punishment. It's a right for them to have an LAI. So you don't want to make it punitive if you're giving them an LAI. It's in their favor. LAIs are very good for medication adherence. Recognizing the warning signs early helps patients and their families learn their unique relapse patterns. Everyone's early warning signs are different, so teach them what to watch for. Reducing stress through practical lifestyles, like good sleep, avoiding substance use, maintaining a routine. These reduce vulnerability to relapse. And then psychosocial support by therapy and community connections, they're not add-ons, okay? We want them to be in therapy. You want them to be involved in their community. CBT, family therapy, and peer groups provide real protection and coping skills for these patients. Frequent contact allows early intervention, so regular clinical follow-ups. Make sure the patients know how to reach you and have a crisis plan. So all of these work together. Don't just pick one, all 5 work together. The goal is to create multiple layers of protection against relapse. Okay, so let's do another quick case before I give you guys a break. So, 34-year-old woman with schizophrenia presents after her 3rd hospitalization in 2 years. Each relapse followed discontinuation of oral risperidone. She states she just doesn't believe she needs the medication when she's feeling good. Wow, isn't that something like I just said that? So, how do you assess insight and capacity for this patient? How would you assess that? Can she understand the connection between stopping the medication and relapse? That would be crucial to know. Okay? What motivational interviewing strategies would apply? So, do you think if you lecture her about compliance, that's going to help? No, don't lecture. Explore her ambivalence. Help her connect the dots between medication adherence and staying well. Is this patient a candidate for a long-term acting injectable? Oh my goodness, if you guys can't answer that right away. She's got some adherence issues, right? So consider offering a long-term acting injectable, like the paliperidone palmitrate. Frame it as a practical convenience option. It's 1 shot a month. You don't have to take those pills every day. You don't want this to sound like, you know what? We're going to give you this shot because this is your 3rd time here. You keep going in the hospital. You're not taking your medications. That's it. You're getting an LAI. Oh my gosh. No, that does not sound like something we can do. We can't frame it that way. Of course not. It's for convenience. Hey, you only have to get this shot once a month. You don't have to swallow the pill every day. This would be very beneficial. It would probably work great with your lifestyle. Use shared decisions, so present options, discuss pros and cons, involve her in the choice. She will probably choose that LAI because it's sounding really good. Family engagement, of course, help with monitoring, those early warning signs, but get their consent first. Document everything, your capacity assessment, what you discussed, her understanding, her treatment preferences. This protects both you and the patient ethically. Remember the tension she may lack due to her illness, but we still need to respect her autonomy while advocating for her well-being. So LAIs, they're significantly underused despite, the strong evidence for preventing relapses. We need to change how we position them. So identify candidates. Look for patients with repeated relapses or clear non-adherence issues. Don't wait until it's the last resort. Bring this up proactively as a clinical option that offers convenience. Know your options and match them to the patient's needs. Paliperidone palmitate offers flexibility. It's monthly, quarterly, or every 6 months. Aripiprazole monohydrate is for monthly dosing, and then risperidone micropheres and haloperidol decanate, they're alternatives. Always overlap when you're initiating with oral medication first per the product guidelines. Make sure the patient tolerates the oral form before being injected, and document everything: site, dose, lot number, what you discuss with the patient. And then of course, make sure the patient has regular follow-up appointments that are, kept and they're consistent. Track how they're doing symptomatically. Watch for any injection site issues. Monitor for EPS and metabolic changes. And reinforce why they're on an LAI at every visit. That helps with the buy-in and the adherence. So this slide, we've already talked about CBT for psychosis, family psychoeducation, so I'm just going to briefly touch on it. For CBT for psychosis, a minimum of 16 sessions is recommended. The focus is on reducing stress, not eliminating symptoms entirely, but we want to reduce the stress from those symptoms. Use a Socratic questioning to help the patients examine their thoughts, working through belief modification and behavioral experiments. And this works for both positive and negative symptoms, okay? The family psychoeducation, of course, multi-family group models like McFarland, they have the strongest evidence, cuts relapse rates in half compared to standard care alone. And it helps families understand the illness, helps them plan for crisis, and reduce expressed emotion. And it decreases the caregiver burden. The IPS model, individual placement and support, that gets people into real jobs. Work itself is therapeutic, so it improves how people see themselves, reduces symptoms, keeps them out of the hospitals. Employment improves their self-efficacy. They want to be able to take care of themselves. It reduces symptom burden and decreases hospitalization. So you should advocate for vocational services in every treatment plan. Make sure your patients have access to vocational services. Advocate, advocate, advocate. Okay, let's do another case study. This one is on schizoaffective disorder, bipolar type. We have a 29-year-old male presenting with a 3-day history of elevated mood, decreased need for sleep, grandiose delusions, and auditory hallucinations. He reports that hallucinations persisted for 3 weeks after his last mood episode resolved. So, concurrent manic episodes, psychotic symptoms, he meets a concurrent phase criterion, right? That's our diagnostic reasoning. So we're looking at what he's got. He's got a history of psychosis persisting over 2 weeks without mood episode, schizoaffective bipolar type. We're going to rule out bipolar 1 with psychotic features. Psychosis is only during mood episodes. So this patient meets the criteria for schizoaffective disorder because he has both a manic episode and psychotic symptoms that are happening at the same time. The key distinguishing feature, his hallucinations persisted for 3 weeks after his mood episode resolved. So that's critical in finding, that's a critical finding that rules out bipolar 1 with psychotic features. In bipolar 1, psychosis only occurs during mood episodes. Here, the psychosis outlasted the mood disturbance. So, you have to know the timeline. Without knowing when symptoms started and stopped relative to each other, we can't make this diagnosis. So you have to know the timeline. So acute management requires both an antipsychotic and a mood stabilizer that are going to work together. You can either combine them, or you can have them separately. You can use an atypical antipsychotic that has mood stabilizing properties like olanzapine or quetiapine. Unlike bipolar disorder, the antipsychotic can't be stopped when the mood episode resolves. It needs to continue long term because psychosis is part of the core illness. If you're going to use lithium, remember to monitor the levels and check their renal and thyroid function annually. And then, of course, don't forget psychoeducation. You got to help the patient understand that in psychoaffective disorder, mood episodes and psychosis are linked to features of the same condition. So I mentioned clozapine a little at the beginning. Clozapine is the gold standard for treatment-resistant schizophrenia. It's most effective option when other antipsychotics have failed, especially after they failed. 3 clear indications would be failure of at least 2 adequate antipsychotic trials. Both dose and duration matter. So you have to have an adequate trial, not a couple days and then, oh, this didn't work. Persistent suicidality in schizophrenia, schizoaffective disorder, and treatment-resistant aggression or hostility. REMS enrollment, all 3 parties, the prescriber, pharmacy, and patient, must be registered before starting. Now that's changed a little bit. So I don't think you have to be certified, but you still have to enroll. ANC monitoring weekly is intensive and front loaded. Weekly for the first 6 months, then bi-weekly through month 12, then monthly indefinitely. That's a non-negotiable. You have to hold drug counts if the count drops below safety threshold. So very important to monitor this because of the risk of agranulocytosis. That's why a lot of patients don't want to take this. They don't want to keep getting stuck. Serious adverse effects require patient education up front. Metabolic complications like weight gain, hyperglycemia, dyslipidemia, screen them and monitor. There's a risk of myocarditis, especially in the first month. And then cardiomyopathy can develop later. Seizures are dose dependent, so be careful when you're titrating. Other complications, they may have hypersalivation, orthostatic hypotension, and sedation. They're common, but they're manageable. As psych nurse practitioners, we have to be competent in both initiation and ongoing management. This isn't a start and forget medication. Once you start it, you will be on it if you're going to use clozapine. Okay, last slide, and then we're going to take a break. Woohoo! I know you guys are ready. Okay. Suicide risk in schizophrenia spectrum disorders is significantly elevated. Remember I talked about that at the beginning. Use the Columbia Suicide Severity Rating Scale at every encounter. That assesses ideation intensity, plan specificity, intent, and behavior. Always ask about access to means and then document thoroughly. Command hallucinations are a specific red flag. Ask them directly. Do you hear voices commanding you to hurt yourself or somebody else? Can they resist these commands and are they willing to? How powerful does the voice feel to them? This assessment directly shapes your level of care decision. Then risk stratification. Classify as low, moderate, or high. Elevated risk requires action. Restrict means, increase visit frequency, consider hospitalization. Create a safety plan collaboratively with the patient and the family. Document your reasoning in all interventions taken. Structured, consistent assessment at every visit is non-negotiable. Okay. Stretch. Breathe. Rest your mind. Take a break. We'll pick back up shortly, but you need a break. The second half is actually much less than this, but it does include the knowledge check questions. You're halfway there. Take a break and relax. You've gotten this far. This was a lot of material. There's a lot of information that you need. Take a break. Let your brain and your body rest before you pick back up.